Greetings from Hospital for Special Surgery in New York City. I'm honored to have been invited to present my research and experience regarding modern-day selective ACL primary repair to the Pakistani Orthopedic Association at the knee meeting in Karachi. I only wish that I could be there in person, as I have never had the pleasure of traveling to that part of the world. Please keep in mind during my talk that I'm not telling you what is right and wrong, but simply sharing with you my experience so that you can make your own decisions. I'd like to take a moment to thank Dr. Umar Butt, who has adopted many of the principles that I will talk about today and is the catalyst for me being here to share my experience with you. Since the 1990s, ACL reconstruction has been at the center of a one-size-fits-all approach to the treatment of ACL injured knee and has reigned king over all approaches. However, while ACL recon is the cornerstone of surgical treatment, anyone who does this surgery knows that it is in no way a perfect solution. Importantly, despite moving to an arthroscopically assisted approach, the surgery is still significantly morbid to the patient, particularly when autografts are used. With ACL reconstruction being the only solution, we tend to be extremely biased in its favor, and have merely been debating over the best technique for the past 3 decades. However, it seems as if lately the luster's coming off the diamond, as more research is coming out documenting the significant downsides of both the injury and the procedure. Mochuku from HSS sheds light on the significant psychological factors such as fear of secondary injury that plague young athletes trying to return to sport. Puisi details the battles with both acute and subacute depression that causes our patients to struggle. McAlpine's group revealed that ACL recon can have long-reaching and unappreciated effects of increased BMI. And finally, Wang et al. Reviewed nicely the vexing problem of post-traumatic arthritis that we still have not solved in the least, with studies showing that rates after arthroscopic ACL reconstruction aren't much better than those after open ACL reconstruction. And while ACL reconstruction is considered our gold standard, it is my belief that we are not really that good at it. Colvin et al. From Fu's team documented our inability to visualize the femoral insertion completely, leading to non-anatomic tunnel placements and their consequences. Lee et al. Studied vertical tunnel placements that plagued our outcomes for decades. Cristino looked at revisions in pediatric patients, which are all too common, and detailed high complications, ipsilateral and contralateral re-tears, and compromised return to sport rates. Let's be realistic. Our worst outcomes are in the younger patients, precisely the ones that we should be the best in. You figure that pro athletes would have the best results given their extreme physical attributes and the level of support they receive. Well, Modi showed that the re-tear rate is very high in NFL athletes. 50% never play another down after tearing their ACL, and only 28% are still active in the league 3 years after ACL reconstruction. Manoharan looked at 325 NFL athletes over 10 years that had ACL reconstruction and showed that only 60% ever made it back to play at an average of 14 months post-op. And the average length of career after the surgery was 3 years, with diminished productivity at 25 to 50% of pre-injury stats. These data are really sobering. When we talk about the past of ACL repair, we are taken back to the 70s and 80s and the seminal work of Dr. John Fagan. This paper on the 5-year follow-up of 64 military cadets is the single most quoted paper in the history of ACL repair surgery. This paper detailed poor 5-year results after open repair, and it and a few others led to the abandonment of the idea that the ACL can heal. It isn't shocking that the results were poor when one realizes that the approach was via a total knee arthrotomy. All tear types were treated the same regardless of tissue quality, and patients were placed in a long leg cast at 20 degrees for 6 to 8 weeks. What is shocking is that this paper, widely lauded as the seminal paper in the history of ACL repair, was only based on 50% follow-up of the 64 patients, most of it via telephone interviews. I'm not being judgmental, but when viewed through the lens of modern science, this data would not be publishable today. More important to me is to look at my past regarding ACL surgery, because I entered my training in 1995 at Hospital for Special Surgery. I was privileged to train with the best of the best. I was taught at the time that the contact athletes got patella tendon autografts with transtibial drilling and metal interference screws. The less aggressive athletes and women got hamstring grafts with a variety of fixation methods that were evolving at the time. Cadaver grafts were used in the older athletes. I didn't question what I was taught, I just desperately tried to absorb it all and master my craft. I did my sports medicine fellowship in St. Louis, taking care of 3 professional teams and multiple college teams. My first job was at Jacobi Medical Center in the Bronx. I started a program in sports medicine for those patients on the lowest rung of the socioeconomic ladder. I was inundated with the trauma-heavy version of sports injuries. As I struggled to get good outcomes in this population, due to the social determinants of health, I began to realize a lot of things about our healthcare system in the U.S. ACL injuries are ubiquitous injuries for all classes of patients, and not just limited to sporting mechanisms. However, research on outcomes tends to cluster at the private hospitals that cater to those of higher socioeconomic class, including athletes. And thus, we have to admit that our outcomes are inherently flawed by egregious selection bias towards those that are well supported, well educated, and well motivated. When we are academically honest, we can all agree that outcomes are directly proportionate to socioeconomic status. My challenge was that I was tasked with taking care of this population. I am pleased to announce that the recent literature has started to quantify and objectify these inequities in our system. Once we start to discuss things openly, it's my hope that we can positively influence the situation. There's lots of work to be done. It was this challenging environment and these health disparities that pushed me outside of the normative line of thinking that it was recon or nothing. I began to think of the morbidity of the procedure more. Coincident with these realizations, the technology surrounding arthroscopic rotator cuff repair was burgeoning. This was around 2005 or so. This allowed me to treat proximal ACL tears like rotator cuff tears. MRI was also quite advanced at this point, allowing me to predict what I was going to find at surgery. My experience led me down the path of selective arthroscopic repair based on tear type and tissue quality. So, I began to carefully select patients to try this new technique on. My first isolated ACL primary repair was done in 2008, and it took me 5 years to collect 20 patients. My first paper was on 11 patients with over 2-year follow-up. This was the first peer-reviewed publication describing selective arthroscopic ACL repair. Recoveries were fast, complications few, and failures only 1. This was my first presentation on the topic. I honestly think that people thought I was crazy, since no one had presented on ACL repair in decades. I emphasized that I was not trying to say that I was right. Merely, I was trying to start a conversation about the possibilities of using a selective approach to treat ACL injuries where we repair the proximal tears and reconstruct the mid-substance tears. In the decades since that talk, I have performed close to 500 ACL primary repairs. Currently, in my busy knee ligament practice, I use an approach I call ACL preservation. For 50% of my patients, I perform primary repair. But remember, my practice is skewed towards repair since people seek me out for my expertise. For 25% of my patients, I repair a good portion of the ligament and add a graft, what has been called in the past and what I still call augmentation. And for only 25% of my patients do I perform a straight reconstruction. So, I use reconstruction, the most morbid procedure, as my last resort, whereas most of the world uses it as their only resort. I've been using this approach for 15 years now, and I'm quite happy with the results. My research team and I have published over 60 peer-reviewed articles and chapters on the topic of ligament preservation. I encourage you to search me on Google Scholar if you are interested in this topic. Here are just a few of the articles. We have defined the science by looking at the biomechanics of my technique and also the internal brace. We have defined and refined the indications by defining repairable tears, looking at their prevalence, and looking at how age plays a factor in tear location. We have identified the benefits by showing that patients have faster recoveries with less complications, they forget about their operative knee more so than recon patients, and they return to sport faster. And we have religiously reported our results, with more to come. I'm happy to say that there are now many other doctors who have published techniques and results on modern-day ACL primary repair. These are just a few of them, including Dr. McKay from Scotland, Dr. Martha Murray from the US, whose preclinical work on her Bear implant began back in the 90s, leading to her clinical work. All told, her work has spanned over 2 decades. Also Dr. Sonnery Cote from France and Dr. Monaco from Italy. It seems that the conversation that I had hoped for is in full swing. And so, where do we go from here? We can look at the future with regard to indications and technique. The debate over indications continues. While the West is rather liberal with their indications, the Scandinavians are quite conservative. My opinion is that it should be somewhere in between. When the morbidity of the procedure is dramatically decreased, this fundamentally alters the risk-benefit curve. I believe that the old data regarding copers and non-copers is somewhat obsolete. Most of this data was based on short-term follow-up, and likely missed those patients who bucket handled their meniscus after 5 years of coping with laxity. In reality, it is my opinion that the copers were likely those patients who were less lax overall, and the non-copers were the ones who had more laxity. It would be enlightening if we correlated how well people do with the objective laxity in their knee. Does coping merely mean giving up the things that you like to do? With an altered risk-benefit curve, perhaps people don't need to cope, but can get a minimal surgery with a quick recovery and pretty much get back to normal. Just a thought. And it's important that we recognize that there is room for growth. As with most things in the past, we tried and initial attempts were well intended but poorly executed. We can certainly learn from the Lars experience, where it was simply too much synthetic and not enough biology. Further work is needed to identify the point of homeostasis between biology and synthetic. I anticipate that we will make great strides in this area over the next decade. Perhaps the acceptance that there is another way to do things regarding ACL injury will lead to a paradigm shift of how we treat ACL injury that bases our interventions on how the ligament is torn and not just if it is torn. With all of our collective wisdom, it certainly seems to me that we can come up with a more sophisticated approach than the one-size-fits-all approach that we use currently. We'll see. Importantly, I would like to say thank you to my research team. But most importantly, I would like to thank you for the kind invitation to present my research, and thank you for your attention. Enjoy the rest of your meeting.